All right, good morning, everybody. Can you hear me okay online? All right, awesome. So my name is Sarah Dudson, one of the assistant professors here at University of Maryland. I'm also one of the assistant program directors, and I'm honored to be here today. Thank you very much, Amal, for having us sub in for the other folks. Before I begin, I just want to take a moment to recognize Dr. Frank Gabram. I don't know Dr. Frank Gabram, but unfortunately, I did read about his passing yesterday from COVID-19. Just want to take a moment to recognize his time here on Earth. He worked in New York. He's an emergency physician, and he's special, and his story touched me very much because he's a two-time survivor of cancer, first of all. Went back to work on the front lines in the emergency department, and unfortunately succumbed to COVID-19 yesterday. On all accounts, he was a really great guy, and he also dedicated part of his professional work to developing wellness, resilience, and all of the good things in terms of patient care for his patients and in our profession. So let's just take a couple of seconds to recognize him. Thank you. All right, so my talk today will be on the collateral damage that patients face with cardiotoxicities in cancer treatment. So again, thank you, Amal, for having me here today to speak about this. It's the intersection between cardiology emergencies and what's near and dear to my heart, oncologic emergencies. So I'm glad to be talking to you about this today. And how much more specific can you really get than cardiology oncologic emergencies, really? But it's really a great big topic. You think about all the cancer-related emergencies out there and what affects the cardiovascular system, and a number of things come to your mind immediately. Pericardial effusions, pulmonary embolisms, a whole list, vasospasm, etc. So what I want to focus on today is two things that will actually help you on your next shift after all of this COVID stuff is past and gone in distant memory when these cancer patients present to you. So we're seeing more and more cancer in our emergency departments. It's very palpable. The incidence of cancer is growing, and cancer survivorship, especially, that's a positive thing, is growing as well. The two things that I want to go over in the next 20 minutes to discuss with you are a sneaky risk factor that's coming up in terms of what you need to consider when patients with a history of cancer or with active cancer come into your emergency departments to be evaluated, as well as to touch upon and review what we know about new drugs and new cardiotoxicities, something new for you to learn today. All right, let's talk about the sneaky new risk factor. So it's always helpful to think about a patient when we frame a new concept. So let's say you have a 51-year-old woman who comes to your emergency department. She's coming in to be evaluated for some fatigue, some slight chest discomfort. It's non-radiating. She has a little bit of nausea, no diaphoresis, no exertional symptoms. Her EKG looks actually really good. And when you ask her about her primary or her past medical history, she really says she just takes multivitamins, and she denies any of the classic risk factors that you typically would ask about. Sounds pretty low risk, right? Would you say that's low risk?
Yeah.
Yeah. All right. So what if she then mentions that she's a breast cancer survivor? 7 years ago, she was given the all clear after having chemotherapy, surgery, radiation. How does this change her risk profile? It changes it a lot, actually. What if you knew that cardiovascular mortality is actually double in this set of patients? That changes things a lot. So going back to these classic risk factors, we always think about hypertension, hyperlipidemia, obesity, and actually those are similar things that make our patients more prone to having cancers. Is there some kind of overlap that makes them more susceptible to having cancer and having cardiovascular disease? We've talked more in recent years about these new risk factors. So if you've been following along the literature, following along in talks, you've learned about CKD, lupus, you've learned about HIV, chronic alcohol, chronic cocaine, and even the new one, chronic marijuana, being considered as new risk factors for cardiovascular disease. What do all these have in common? It's a lot of inflammation. And so what I want you to consider and what I want you to think about after you leave this talk is to know that cancer is a huge risk factor in terms of cardiovascular disease and cardiovascular health, even during treatment and for years to come after treatment. So again, as I discussed, and as I think we'll hear about more later on today, inflammatory and prothrombotic state that comes from cancer really, really puts you at risk. Metabolic mismatches, so cancer patients are often anemic, putting them at higher risk for having myocardial ischemia. Medication toxicities also cause direct damage to patients at higher cardiovascular risk. And then radiation effects, so especially cancers where radiation treatment is focused on the chest, are very, very susceptible to causing changes that increase the risk factors for patients having cardiovascular disease. This puts together this perfect storm of factors and influences that make patients at risk for ACS, for vasospasm, for congestion, and for other cardiovascular badness down the pike. All these things come together. They cause accelerated atherosclerosis. They cause endothelial destruction within the coronary arteries as well as the peripheral arteries. They cause a hypercoagulability and thrombosis state. And of course, everybody knows this. Your cancer patients are at higher risk for PEs during cancer treatment, but also later on. And then they cause direct myocyte damage, and this causes a decreased LV ejection fraction, causes a myocarditis, and major issues with that. So here I have this table. Of course, if you're emergency medicine, if you're a GP, you don't need to know all the specifics about this. All you need to know is that all these chemotherapies, all this radiation, it can cause immediate effects and it can cause latent long-term effects. And you need to keep that in mind, especially when a patient is presenting to you who has a distant history of cancer. You can't forget about that, and you've got to consider it, even if it's way, way, way back in the distant past. Speaking of that, don't forget about pediatric cancers and young adulthood cancers. Patients don't want to bring that up. They don't want to remember that, but it's important in terms of their risk factors. These couple of studies show some really sobering facts about what can happen when patients go through and they survive, but this is the collateral damage that they're left with. They've got really, really, really elevated risk for having major cardiovascular events. And again, I want you to remember that. This shows you kind of how everything comes together and puts patients at higher risk for ACS in particular. And as I discussed, there are multiple cardiovascular conditions that can occur, but ACS is one that we're evaluating for all day, every day in our emergency department. And again, we need to consider this when cancer patients come in as an additional risk factor. What about STEMI in cancer patients? So PCI is actually an interesting kind of conglomeration and decision when you have a patient presenting who has especially active cancer. It's a tough decision, and when your interventional cardiologist comes in and you're consulting them for cath lab on these patients, it might be a good idea to know kind of what might be going through their heads. So in terms of stenting these patients, you want to think about their overall prognosis, right? If they have really advanced cancer, what is this management and this intervention going to do long term? What are the risks of dual antiplatelet therapy after getting a stent and their bleeding risk? And what we've learned more recently is that malignancy may be a key risk factor in early stent rethrombosis. So this, again, is what your interventional cardiologist is thinking about when they are like, I'm going to take this patient to cath, or I'm not going to take this patient to cath, please do medical management. I want you to understand that. These are just summaries of a couple of studies to give you a background of what's going through their head. It's not good. So in 2013, 2017, et cetera, a few studies came out showing, of course, that patients with active cancer don't do as well as patients without active cancer. And this goes along to support that interventional cardiologist and being hesitant to take patients to cath lab. However, there might be some changing tides in this. So more recent studies are showing that PCI for STEMI in patients with cancer don't show worse outcomes in hospital. And that may be because of better technology nowadays. We're able to use intracoronary imaging and ultrasound to help with placement of the stents and to evaluate where they need to go. And then drug-eluting stents, the use of those in terms of versus using bare metal stents. Those have been shown to show better outcomes as well. So we're trying to kind of push ahead in terms of active cancer patients going to PCI, and knowing this data will help to inform you in your discussion with the cardiologist. So key points for this first part of the talk. Please make sure that you consider a history of cancer or active cancer as a very, very important cardiovascular risk factor in patients presenting with chest pain, shortness of breath, or other equivalents. And then PCI decision is very complicated in cancer patients, but it seems like data is leaning towards going ahead and taking them to intervention as opposed to medical management. All right, so let's move on to the next topic. We talked about our sneaky risk factor. Now we're going to talk about new drugs and new problems. So this patient is a woman with non-small cell lung cancer. She is presenting to you with shortness of breath and some fatigue as well. Fatigue is a major, major issue going on right now. You look into her history and you ask her about her treatments for her non-small cell lung cancer. She tells you that she's gotten 2 doses of nivolumab and ipilimumab. And this is your reaction. So let's take a time out. Let's do a little very quick review. Let's buckle up and do a review of what this immunotherapy, what the epimabs are. So checkpoint inhibitors and immunotherapy are the newest line of cancer treatments. It's looked at almost like a panacea for cancer at this point. It's something completely different and uses a different mechanism. Therefore, it also causes different toxicities. Going back to looking at traditional cancer therapies like chemotherapy and radiation are cytotoxic. So their goal is to just blanket kill everything. So that leads to what side effects we commonly see. However, when you look at cancer immunotherapy, this was developed to selectively kill cancer cells and hopefully leave others alone. And it does this by revving up your immune system and using your immune system to work against your cancer cells. Now, there are different flavors of immunotherapy out there. What I'm going to focus on is the checkpoint inhibitors, and that's one of these therapies again. You may be familiar seeing commercials, seeing your patients come in on these medications, and a lot of them do end with UMAB, so that's a good way to remember and to pick up on those. Many patients will be on combination therapies of either multiple checkpoint inhibitors or combinations of checkpoint inhibitors and traditional chemotherapy. So let's go through the pathophysiology. Not really, no, we're not going to do that. So all I want you to know about checkpoint inhibitors is to think about the immune system as this race car. Checkpoint inhibitors basically take the brakes off of that immune system and the natural processes that keep it in check and let that immune system go and work against the tumor cells. That's the basic idea. So in terms of immunotherapies and their cardiotoxicities and their toxicities in general, again, we can't avoid this collateral damage. So there are things that we need to look out for as emergency physicians that we'll see in patients presenting and coming to the emergency department who are on these treatments. Now, when you have something that works against the immune system, it can affect pretty much anything in the body. So, unfortunately, we see lots and lots of generally mild effects, but they affect anything from the skin, the eyes, the GI tract, the lungs, and the heart. The most common reasons for patients coming into the emergency department, again, are this diarrhea and colitis that you can see, pneumonitis, dermatitis, and then hypophysitis. But we're here to talk about the heart today. And what we're going to talk about for the next 10 minutes or so is checkpoint inhibitor, immune checkpoint inhibitor, cardiotoxicities, mainly myocarditis. Pericarditis can be seen as well. You'll have a talk later today about pericarditis and other things, and as well as myocarditis in a different setting. But what we'll talk about is immune checkpoint inhibitor myocarditis, how you can pick it up, what you'll do to treat it, and how patients present. So immune checkpoint myocarditis, what we know so far, and this is a under-recognized phenomenon or toxicity. We're learning more and more about this every single day. And if you look at the immuno-oncology literature, this is what's hot right now. The incidence, as far as we know, is pretty low, but again, we suspect that the incidence is underrepresented and it's underreported because we're not recognizing it. What we know so far in terms of numbers is that the incidence may be 0.04 to 2%. Mortality is ridiculously high. So again, this is a broad range, but we've got anywhere between 25 to 50% of patients who get this. Again, we think it's low numbers, but it has an incredibly high mortality. The median onset is about a month after patients are initiated on their treatment. Most patients who present with myocarditis start with symptoms within 1 or 2 doses. This is a table from JAMA Oncology. Again, I just want to highlight the mortality here. On the left side of the screen, you can see the incidence in terms of comparison with other adverse events related to immunotherapy and the checkpoint inhibitors, and then the fatality rate. And you can see this big jump right here is in that myocarditis. So in terms of its presentation, it's similar to other presentations of myocarditis. Patients may have chest pain, shortness of breath, signs of heart failure. Workup is going to be the same as well. So you're going to get your troponin, you're going to get your BNPs, you're going to do all of your similar workup, and you're really going to use that ultrasound to help you out in terms of looking at what their ejection fraction is, what it's looking like, and what their cardiac function is like in real time. that's going to be major and key. Now, in terms of treatment, this algorithm is published from the American Heart Association. It's very specific, and it's meant for inpatient oncologic/cardiology treatment of this. Now, in the emergency department, if you have a patient who comes in who's been on checkpoint inhibitors presenting with something that sounds like myocarditis, you want to pick that up right away, consider it as the diagnosis, and talk to your oncologist and talk to your cardiologist about starting the patient on treatment. And that treatment will entail very, very high dose steroids to start out with. If they're refractory to those steroids, then there are other treatments involved, but those are going to be down the line. So we're talking high dose like methylprednisolone, 1,000 milligrams in a single dose. In addition to myocarditis, and as a complication of myocarditis, one thing that I want you guys to pick up on as well and look for is dysrhythmia associated with it. So in the setting of a patient on immune checkpoint inhibitors, any new conduction abnormality can be this canary in a landmine of canary in a cave. What is it? Coal mine. I don't know. English is not my first language. So it can be a red flag for patients decompensating into needing a pacemaker, into needing help with in terms of their dysrhythmia. So for example, this EKG, I know you can't see it super well, but this is a baseline EKG from a patient before they were started on immune checkpoint inhibitor. Everything looks pretty normal. This EKG is after their second dose of checkpoint inhibitor. And you can see there's a couple of PVCs that jump out at you, but they have a pretty significant first-degree AV block there. And if someone just handed you this EKG, you might not be that impressed with it. However, again, these patients can decompensate very quickly and require pacing. So if you're faced with this patient, look for that little clue and that little red flag and make sure that you're all ready in case they do decompensate. So put the pads on, get ready to float that pacer if you need to, and admit them for further management. Key points from this section. In terms of myocarditis, apply your ultrasound skills, look at the EF at the bedside. Detect it early because mortality is super high. So you want to get oncology and cardiology on board very early and start those steroids if your suspicion for myocarditis is high in these patients. And use your EKG skills. So any minor conduction abnormality is the canary in that coal mine, and make sure that you light up everyone that you need to in terms of bringing them in for monitoring and looking for any kind of blocks that degrade. Thank you very much, you guys, for listening today and for taking time out in your busy lives right now. I want to thank everybody for what you do on the front lines, what everybody behind the front lines is doing administratively. We are emergency medicine, and we're leading the fight here in this COVID crisis era, and I wish everybody well and safety.
Join sending them to you for this question. Hold on, I can see.
Okay, question.
Thoughts on treatment of ICI, myocarditis treatment in the time of COVID? Steroids?
No. Oh my God, that's a loaded question. So in terms of thoughts on steroid treatment in the time of COVID, if you have an ICI patient coming in who you suspect myocarditis. Right now, everything is COVID. Everything myocarditis has to be COVID. So I would say that right now, as it stands, I would hold off on steroid treatment for what we know about. I mean, things with COVID are changing every single day as well. So tomorrow we might be like, everybody needs steroids. But from what we know right now, we're holding off on steroids.
We've added CKD and HIV as risk factors in the heart score under risk here at university. The question is, would you add cancer as a coronary risk factor?
100%. I would add history of cancer, current cancer as a risk factor in the heart score.
Current or past?
Yes. Current or past.
That's all I see.
Okay, I think we just tell people we're going to take a 15-minute break.
Thank you, everybody. We're going to take a 15-minute break. We'll see you on the other side.